My name is Liliana Knežević, and today I'm going to be presenting about conflicting breast cancer screening mammography. There is no topic or medical concern that caused so much controversy or dividing opinions. Today I'm going to be talking about history of the breast cancer and the screening mammography, about statistics on breast cancer, screening recommendation overviews by different organizations, risk of developing breast cancer, benefits versus harms when it comes to screening mammography, confusion and adherence, and finally conclusion. History of breast cancer goes back to the ancient Egypt, and the first text written on breast cancer was found around 1600 BC, where doctors back then tried to treat this disease and they described it as just there is no treatment. Not much actually changed throughout the history until a radical mastectomy is removal of the entire breast, lymph nodes, and the muscle. First mastectomy performed in the United States was in 1882 by surgeon William Halsted at Johns Hopkins University Hospital. It took almost a century until first lumpectomy was developed and performed in 1970s. Lumpectomy is also called breast preservation surgery because it doesn't remove the entire breast as mastectomy did previously. It only removes breast tissue that's affected by breast cancer. In late 1980s, some studies proved that patients with lumpectomy and radiation therapy have same 5-year survival rate as those that had mastectomy. American Cancer Society developed a program for the screening, with the purpose of detecting breast cancer in early stage when it's highly treatable. Today, breast cancer is second leading cause of death among American women after lung cancer, which is in first place. Every year, over 232,000 women are diagnosed with breast cancer, and approximately 40,000 of them die every year. Here there is a table of the screening overview by different organizations. So we can see where is confusion coming from actually. Like I said before, American Cancer Society first developed screening guidelines in 1976 and they changed over the next few decades. Last change was in 2015 where American Cancer Society stopped recommending beginning screening at 40. Instead, now they recommend beginning at 45. And also, after age of 54, they don't want women to do it annually, they want them to do every other year. This change came 6 years after another organization developed their new guidelines in 2009, and they start recommendation for starting screening mammograms at age of 50 and doing it biannually. There's other very important organization when it comes to breast cancer screening guidelines. There is American College of Radiology, who still highly recommends starting screening mammograms at the age of 40 and doing it annually. Same thing is with the American Society of Gynecologists and Obstetricians. They also recommend starting at the age of 40 and doing it annually. So most recommendations differ in age when to start and actually frequency, how often patients should do it, either every year or every other year. It's very important. They apply for the women with average risk, which means the women that have increased risk of breast cancer, they have different recommendations. Increased risk of breast cancer is family history of breast cancer. If patients tested positive on some genes, they cause breast cancer and ovarian cancer. Then increased age, because we know as women get older, there is more chance they get breast cancer. Being women increases chance, and also smoking and obesity. Benefits versus harms are the things that are actually basics for the screening guidelines, because in screening guidelines, scientists trying to prove how much women benefit versus how much they're exposed to the risks during the screening guidelines. Some scientists believe the benefits of catching the breast cancer early are actually outweighed by the risk of overdiagnosis, of false positives, additional imaging that goes, then this stress the patient goes through, and of course, the biggest concern is radiation exposure of the patients. Patients are confused because when they go on internet and they read different organizations recommend different things, they don't know anymore what to do. Not only patients are confused, but also physicians, because they don't know what really to recommend to their patients. For now, all patients should know that they should start at least talking with their physicians at age of 40 about starting to having breast cancer screeners. They should find out as much as they can about their personal medical history and their family medical history. Patients should be communicated so they understand their benefits doing screening mammography, risks, and also they would discuss with their doctors what best. They say that we want a patient-centered care, and then this is exactly what we are getting here. Because we all agree that more research has to be done on breast cancer, but before that, we all agree that patients should communicate with their physicians and create their own personal plan for the breast cancer screening, which means every individual is unique. They have their personal history, their family history, and then they should communicate it with their doctors. And then instead having guidelines in fashion, one fits all, we have to have personalized breast cancer screening guidelines. Thank you so much.